Okay, hello everyone. Welcome to today's lecture on myopia management. The lecture is going to be a little bit more formal because we're videotaping, so I'm going to talk about like research and stuff like that. But it's also important that you guys know why it's important and what the purpose is and what the options are, so that you can talk about it with patients and or understand like why things are priced the way they are, stuff like that. So let's get into it. So first, most important aspect of the lecture is that we understand what myopia is, right? So we know myopia more commonly as nearsightedness, and this occurs because the eye is a little bit longer than where light focuses. So in someone that doesn't have myopia or doesn't require glasses, essentially, when light enters, it's going to focus perfectly on the back of the eye. In a patient that has nearsightedness, when light enters the eye, it's going to focus in front of the back of the eye. So we have to utilize glasses or something to refocus the light so that it focuses where we need it to. When their vision is uncorrected, so without glasses, contacts, etc., they have blurry vision. They can see pretty well up close. Depending on their prescription, we'll decide like how close they can see well without glasses, but the distance will be blurry. Okay, so myopia is currently a global epidemic. So the amount of people in the world with myopia is growing pretty rapidly. Currently, about 30% of the world's population has myopia already. And there was a landmark study recently that predicted that by 2050, half of the world's population was going to be myopic. And because of that, there's going to be almost 1 billion people with high myopia, so a -5 or higher. And so as an eye industry, essentially, we're looking at ways to prevent the complications that come with myopia because so many people are going to have it. Okay, so in looking at how we're managing myopia, all of us are very familiar with these options here. So certainly one major component of myopia management is correcting the patient's vision. So we don't want anyone walking around with blurry vision. We can prescribe glasses, we can prescribe contacts. At a certain age and stabilization of refractive error, we can prescribe LASIK, surgical, refractive surgery essentially. But this is only one piece of managing myopia. This is only providing them with clear vision. So we have to think beyond just the blurred vision because there are pretty significant associated risks that come with someone that has myopia. These are listed here. So for example, people with myopia have a higher risk of retinal detachment. They have a higher risk of myopic macular degeneration. Both of these can be visually pretty devastating. And then also other conditions like glaucoma and cataracts are more common in these patients that have myopia. Okay, so previously we kind of thought that only patients with a certain level of myopia were at risk or at higher risk for all of these sight-threatening conditions. But current research is essentially showing that regardless of your level of myopia, you have some aspect of risk for those sight-threatening diseases. Every 1 diopter will increase the risk of all of these complications by a certain amount. So even someone with just a -1 prescription already has a 58% increased risk of myopic maculopathy, which is visually devastating. And then in looking at the people that have myopic maculopathy, we typically would think, okay, maybe our -6s, -7s, we expect that. But of that group with that condition, 30% of those people are people below a -6. So we can't just worry about our higher prescriptions at this point. We need to worry about our lower myopes as well. Okay, so in addition to looking at the risk factors and things with myopia, there is a benefit to having lower myopia in terms of quality of life. So this picture here is the CooperVision myopia simulator, and this is supposed to be like clear vision. So we're looking at how a child with fully corrected or no glasses, doesn't need glasses, will see the classroom. When we change the simulator to a -1 prescription, you can see the board is blurry, but there's still pretty good detail. Like you could walk around this classroom with this vision and ideally we would correct them, but you could be functional if you lost your glasses at recess, or if you're on a trip and you lose your glasses, your quality of life isn't going to be completely impacted. Whereas when we're looking at someone with a -3, or even worse, a -6, this whole classroom becomes out of focus, right? This is just a simulator, so it's not exactly how it would look, but to kind of function in this setting with a -6 prescription, if you lost your glasses at recess, not going to be very functional. So we're also looking at quality of life by reducing the amount of myopia that these kids experience. Okay, so who is at risk for developing myopia? And further than that, who's at risk for high myopia? So children that develop myopia really early, essentially they have a longer period of time where they can develop high myopia, right? So if you are diagnosed with myopia at 5, now you have till your early 20s to progress into higher and higher myopia. So being diagnosed at a younger age is definitely a big risk factor. Genetics plays a big role. So if both of your parents have myopia, you're already at a 3 times higher risk to have myopia than someone whose parents don't have it. And then we're finding associations of myopia with lots of near work. So this could be like reading really close, but it could also be probably more likely iPads and phones very close. And then in turn, these kids aren't spending as much time outdoors. So kids that are kind of inside doing things up close are at risk for myopia. Okay, so I've probably convinced you all that you don't want to have myopia if you don't need it, or if you don't have to. So how do we prevent it from onsetting in the first place? Research is showing that kids that spend more time outdoors, 2 hours plus per day, have less of a risk of developing myopia in the first place, so it can slow or prevent onset. Also, taking breaks with near tasks, so you don't have to never read a book again as a child or never go on your iPad, but doing like a 20-minute session on your iPad and then spending 20 minutes outside will help to prevent the onset of this. And then lastly, having your eye exams earlier so that we can intervene earlier if these patients have myopia. That way we can prevent it from getting so high and prevent those risk factors from occurring. Okay, so this brings me to myopia control. So the goal of myopia control is essentially to slow the progression of these kids that have been diagnosed with myopia. Once you get to a certain level of myopia, we can't reverse that. So we have to act early to prevent it from getting to that point, because once it does, there's not really much that we can do. One thing to note is that we can't stop progression altogether. We can only slow it. So none of these methods will completely stop progression. And so we should never set that expectation for patients that it's going to be stopped. It's going to be slowed, and the rate at which it's going to be slowed kind of depends on the patient. Okay, so a lot of these patients, you'll kind of talk to them about the risks and things like that, and the parents will say, well, they're just going to get LASIK when they're 20, so it doesn't really matter if they're blurry without their glasses now, because in adulthood, they're going to have great vision. Oftentimes, these are parents that have myopia that got LASIK, so they're like, I'm doing fine, so why does my child need to do this? But there's important caveats that come with that. So LASIK occurs on the front of the eye, on the cornea, and it essentially changes the cornea so that light will focus in the right place. It doesn't change the retina at all. So everything that has occurred from that myopia, that retina thinning, stretching, all of those risks of complications still exist, even if they get LASIK, because none of that has to do with this. Also, if their prescription gets to a certain severity, I guess, they no longer can be considered for LASIK. It has a lot to do with how high their prescription is, how thick their cornea is, so there's no guarantee that this child is going to even be a LASIK candidate down the line. And then certainly with any medical procedure, there's side effects, risks, but also something to consider. This is an elective procedure, so if we can avoid the side effects that come with it, that would be great. Okay, so how do we do myopia control? There's 3 evidence-based ways that we're practicing right now. Myopia control is an area of, like a huge area of research right now, so there's always new research. There's potential for new treatments down the line, but as of now, these are our 3 that we feel confident practicing and are kind of standard of care across the country. Okay, so you guys are familiar with orthokeratology to an extent. So ortho-K is a rigid lens. It's not like the soft lenses that we're traditionally used to seeing. And it's worn by the patient at nighttime while they're sleeping. And the goal of the lens is to reshape the front of the eye, the cornea, so that when the patient wakes up, they can see clearly. So how does that happen? So ortho-K have very advanced designs. It's called a reverse geometry lens, and essentially it utilizes hydrostatic forces so that the cornea will be reshapen into almost like a bullseye pattern. So this picture at the top is of the lens fit, and the picture at the bottom is of a topography. So when we're looking at the center here, this blue-green area represents an area of flattening, and this red area represents steepening, or you can think of it as like elevation. So this is kind of flatter, this is higher, and that's going to result in clear vision for the patient. So with ortho-K, we're doing 2 things. We're correcting the patient's vision during the day so they can see well, but at the same time, we're creating this elevated area, which results in what's called peripheral blur on the retina in the back of the eye, and this is the mechanism that slows myopic progression. So good vision while also providing a myopia control effect by them wearing these lenses at nighttime. One important thing to note is that when you think of this and you look at it, you might assume like, okay, this lens is like pushing down on the cornea, it's rubbing, it's causing damage, but this lens is actually completely, there's a full tear layer underneath the lens. So the lens is not actually contacting the cornea itself. There's tears beneath it. And the cells are not being damaged, redirected, anything like that. It's the fluid in the cells of the cornea that's being redirected. So let's say we take this patient out of ortho-K, within 2 weeks, a month, their cornea is going to be completely back to normal, no damage. And that's part of the fitting process, is us making sure that it's fit well so that it doesn't cause any dryness, damage, anything like that. Okay, so here is a study. This was one of the earlier ortho-K studies that kind of was landmark in terms of starting to use ortho-K for myopia control. It utilized 102 children aged 6 to 10, and some of them were put in ortho-K, some of them were put in glasses, and then over the course of 2 years, they assessed how the eye was growing. And ultimately, from this study, they concluded that ortho-K slowed eye growth by 43%. So again, we're not stopping it completely, but we're seeing slowing. And then because of this study, and then studies that have come since it, the FDA approved the first ortho-K lenses for myopia control in May of 2021. So we've been using it off-label for this purpose up until this time, but now the FDA is acknowledging that there's enough evidence that this is important to use. Okay. Of course, there's always considerations when we prescribe something, right? So you probably hear us say all the time, like, never sleep in your contact lenses, and now we're saying sleep in them, which seems confusing. There's still a risk involved with wearing the lenses to sleep, certainly. They've done research, and there's within the research, about 7 out of 10,000 cases where an infection occurs because of ortho-K lens wear. This is different than soft lenses, which is actually a higher rate, 25 within 10,000. So it is a little bit safer for wear at night. The main thing we have to harp on is hygiene. So these patients need to be washing their hands, they need to be using good cleaners, and they need to be doing it every single day so that they're not wearing dirty lenses to sleep. And then also, not every patient is a good candidate for ortho-K. So we have to do a full eye exam. We have to look at the curvatures of their eyes. We need to know their prescription. Do they have astigmatism and all of that? So not every single patient can be put in ortho-K. And then for Ortho-K to provide you with that good vision and in turn that myopia control effect, they do have to sleep in them every night for 8 hours. So let's say one night you're only getting 4 hours of sleep, you're gonna wake up, your vision's probably gonna be a little bit blurry. This is something that we often consider with like our teens or early college age students. If you're in college, you're probably not sleeping 8 hours a night. That's just how it is. So if these patients still need to be in myopia control, oftentimes we'll switch them to something different. So that's just something to keep in mind in terms of lifestyle. When we're choosing a modality for a patient, they need to wear it for 8 hours. And then even though their vision is corrected well with the lenses, they still need to have backup glasses in the case of a washout, infection, lost lenses, etc. So that's still important. And then we recommend that these lenses are replaced every year for a couple of reasons. So again, we want to be as cleanly as possible. So if we can replace them yearly, lower risk of infection. Also, these lenses can warp. So you're like sleeping in them every single night. Your eyelid is going to have an impact on the lens, which can change the way it's fitting, the way it's treating, and can affect that myopia control effect. Okay, so Ortho-K, second option, soft multifocal contact lenses. You guys are probably more familiar with the MiSight lenses is something that we fit here for this. This is kind of the opposite of Ortho-K. So Ortho-K, they wear it at nighttime. Soft lenses, they wear it during the day as their primary form of correction. And then it also provides that myopia control effect. So keeping in mind how the Ortho-K has that area of steepening to create that myopia control effect, these multifocal lenses create that steepening a little bit different. So it utilizes extra power in the periphery of the lens in order to create that blur that results in the myopia slowing. So these lenses are designed, the center is designed for distance, so they're seeing very clearly through these lenses. And then the outskirts of the lens is designed to create that blur in the periphery, so not affecting their vision, but slowing the myopia. Okay, another clinical trial. So this was the clinical trial that was utilized to approve MiSight for FDA use, or FDA approval for myopia control. Essentially 144 kids, 8 to 12. Some of them were in MiSight, some of them were in just regular single vision contact lenses. Neither group knew who was wearing which. And then after 3 years, they assessed progression. And these lenses were found to slow progression by 59% in this study. So utilizing this research, as well as other research regarding this modality, FDA approved the MiSight lenses specifically for myopia control, which we oftentimes extrapolate that to utilize other designs of multifocal lenses to do the same thing when needed. Okay, so more considerations. Of course, with every modality, we have to consider things. Contact lens hygiene continues to be important for these kiddos. Typically, we use daily lenses for kids that are doing myopia control. MiSight is a daily lens. We just got in Natural View, that's also a daily lens. So that kind of eliminates some of the difficulty with hygiene in terms of doing the daily, but still emphasizing hand washing, emphasizing tossing the lenses at the end of the day, not sleeping in them, all of that is super important. Another thing to consider with this modality is that they're wearing them during the day. So some families prefer Ortho-K because all of the lens handling happens at home with the parents. Whereas with these lenses, maybe the parents are there when they put them on in the morning, but then they send them off to school and now they have lenses in their eyes and their parents aren't around. And so we need these kids to be of an age or mature enough where they can hopefully handle lenses on their own so that if something happens at school, they can deal with it independently, basically. And then just like Ortho-K, depends on the prescription, things like that, if we can fit them in this modality. And then also like Ortho-K, but the opposite, they need to wear them for 8 hours per day for the best myopia control effect. So these kids can't wear glasses Monday, Tuesday, Wednesday, Thursday, and then contacts on the weekends. They have to wear them daily and they need to do it for 8 hours. So something to consider also. And then again, glasses, they do need glasses, even though we want them wearing these every day, they still need glasses as backup. Okay, third option is low-dose atropine eye drops. So historically, atropine was used in offices to dilate eyes, and it's a non-selective anti-muscarinic drop, and it acts on the ciliary muscle of the eye, and has been demonstrated to have a myopia control effect. There's research that's ongoing. We still don't really know why it has the myopia control effect. We just know that it does. And there's kind of a wide array of literature in terms of how grand the myopia control effect is. There's literature that says 30, there's literature that says 80, so we can kind of guess that our patients will experience something within that realm. And then there's been a lot of studies on atropine, especially more recently. This is the LAMP study. It was a two-part study that looked at different percentages of low-dose atropine, so comparing like a pretty low dose to like a slightly higher, all of which are really low-dose atropine, comparing that to a placebo drop essentially and seeing if it was successful in slowing myopia. What they concluded was that all of the concentrations did demonstrate slowing. 0.05 demonstrated the best efficacy, and then all of them were well tolerated, and patients didn't have like huge visual effects or quality of life changes because of the drop, which is really good. Okay, so we talked about how historically these drops were used for dilation, but now we're utilizing a super low dose of them for this purpose. So there is a chance that they'll still have some mild pupil dilation. They may have some light sensitivity because of that, and sometimes their near vision and focusing is affected a little bit. So what are we going to do about this? First of all, we're always going to have them put it in before bed, so kind of the peak of these symptoms happens while they're sleeping. And then we can also do things like taper the dose down. So if we put them on 0.025 and they're having pupil dilation that's affecting them, we could always taper down. And we can also prescribe bifocals if they're having trouble with reading up close. So we can kind of give them that boost that they need to enable them to stay on the atropine. And then because it is a drug, there are some potential systemic side effects. But one thing to note is that 1% atropine is FDA approved for 3-month-olds and older. And we're using like 1/100th, 5/100ths of that drug. So if that is safe for 3-month-olds, the really, really low dose really rarely has systemic side effects. So generally we could say probably safe for our patients. And then another thing to consider is that we can't just get this eye drop at any pharmacy because it's compounded. So we have to order from particular pharmacies, which kind of adds to the whole production of things. And then lastly, this is the easiest one to forget. So someone with ortho-K, probably not going to forget to put their lenses in because they know tomorrow they won't be able to see anything. And soft lenses, they're going to put them in to be able to see at school. With this, it can be easy to forget an eye drop at nighttime. So you have to encourage patients to make it part of their nightly routine. So when you brush your teeth, you do the drops, or put a sign on your mirror or something like that to kind of help you remember to do the drops. Okay, so we've talked about options, we've talked about percentages, studies, things like that. So which one should I do? Which one's best? The answer is we don't know, and it depends. So this selection process is super patient specific in regards to, number one, what we find in the eye exam. What are they even a candidate for? That may narrow things down, that may still open up all of the options. And then we kind of dig into what's your lifestyle. Is it important that they don't wear contacts during the day because they're a swimmer? Or would they prefer to do eye drops because that's the easiest? What would be best for their life and the parents' lives as well, because they're going to be really involved in this process. And then we also consider patient age and maturity. So we kind of talked about that already. If they're going to be wearing lenses to school, they need to be able to handle those things. Do they have the maturity to sleep in the lenses, things like that. So because we don't know which option is best for the patient, we have to monitor to see if they're progressing even with the modality. So typically we'll follow up every 3 to 6 months, depending. And this is why we do that axial length measurement. So axial length refers to the length of the eye. And we know that myopia refers to an eye that's longer than we want it to be. So if we're seeing the eye grow over time, then we're seeing progression. We can also assess their prescription, but with ortho-K that becomes more difficult because the cornea is reshapen and all things like that. So we always will do axial length, and then we'll do spectacle prescription for atropine and multifocals, and then sometimes we'll wash out our ortho-K patients so that we can look at their true glasses prescription. And then at these visits, we also need to make sure that these modalities are treating their eyes well. So we need to make sure their eyes look healthy, they're able to see what they need to see, able to function in their daily lives. So all of this is important in these follow-up visits. Okay, so let's say they come back and they're progressing. What do we do now? So for one, we already talked about we expect some progression, right? So we're not stopping progression, so we would be surprised if we saw no progression at all. Is that progression outside of what we normally expect to see? Then we have to take action. So at this point, we have a couple of choices. We can either switch to something new. So if someone's an ortho-K and we're seeing a lot of progression outside of normal, maybe we could switch to atropine. Or we can consider combining treatments. So research in terms of combination treatments is still ongoing. We're not sure if these combinations have like an additive effect or not based on research. But at this point, if they're already progressing, we might as well add to try to slow the progression because we're kind of out of choices at that point. So switch or combine is kind of how we'll tackle when we see progression outside of normal to try to slow. Okay, and then, okay, I've been in ortho-K for like 10 years. Can I be done? When does myopia stop progressing? So the COMET study looked at myopia progression in a lot of different aspects, but one of the things that it published was kind of age of stabilization. So we'll tend to do myopia control until patients are in their late teens, early 20s. And then even after we stop myopia progression or myopia control, we need to keep monitoring them, because if we are going to see significant progression following stopping myopia control, then we need to probably restart it, because not 100% of patients are stable by their early 20s, but most of them are. So we don't want to take people too far, but we want to make sure we're acting if we're still seeing progression.